I am honored for this opportunity that IP invited me to introduce the Cisternostomy. And so I'm very glad, and I have many experience about Cisternostomy. At the beginning, I learned from the Professor Cherry, and we have communicated many times. Uh, so, and recently, I will establish a society of traumatic neurosurgeries. So I have a lot to say. Maybe in the future, we will have some conference and invite all over my brothers to China and have conference. Uh, this time I will introduce pathophysiology of cystostomy. Actually, the cystostomy is has a long history. This is last century. This paper is from America, and this use unilateral inferior temporal uh, lobotomy with hemicapectomy for relief of incisional herniation. And this this procedure is simple than cystostomy. Actually, they use cystostomy idea. They open the skull and cut temporal lobe and open the incisional system, ambient system. And at this time, a lot of CSF come out. Th this method is very good. I use this method to do several patients. At this time, when we open the ambient system, a lot of CSF come out, and the ICP is lower, so we can clear the brain laceration and hematoma. So it's good and lower the ICP. This paper is about from Japan. Is about aneurysm, ruptured aneurysm, and use basal cyst drainage and lumbar subaqueous drainage. It's also use cystostomy technique, so it's have a good result. This paper is from China at 1995. This is also used cystostomy in brain trauma. They have severe brain trauma, 22 cases use cystostomy and have a good result. They can reduce brain stem compression and reduce traumatic hypocephalus and reduce ICP. And use this drainage about 5 days to 7 days at this base drainage tube height is 10 millimeter high. So it's a very good result. This is Professor Iper's paper about cystostomy for traumatic brain injury. And at this paper, they tell the procedure how to do this surgery at some pathophysiological mechanism and surgical technique. It's very good paper. And cystostomy also use stroke-tomy and brain infarction, especially malignant middle cerebral artery infarction. I also use cystotomy to do this surgery, middle cerebral artery infarction. It's also have good result. At the from 2012, the pathology of cystotomy at Dr. Elif Nedgard identified glymphatic pathway. This is very important for our understand the cystotomy theory. At the this is glymphatic pathway. At from this paper, we identified blue-wide pathway for fluid transport, which includes arterial influx of subarachnoid CSF into the brain interstitium, and also institutional bulk flow between this influx and the efflux pathway depend on astrocyted water movement. This pathway is called the glymphatic pathway. When we find this pathway, we will also better understand the cystotomy is a good method of surgery. This paper is very important for our understand because before there's a lot of paper about animal result. This paper is research from animal translated to humans. This paper write about blue-wide glymphatic enhancement and clearance in humans accessed with MRI. And this is different time, 2 to 4 hours, to 4 to 6 hours. The glymphatic system in different phase, and we can understand the human brain also has glymphatic pathway. And at this, the current pathways recognized for the exchange of fluid within the cranial compartment. This is a new hypothesis. The fluid exchange between the system and parenchyma through the perivascular virtual robot space may be greater importance than the traditional recognized fluid within the ventricular system. So, so we should understand this glymphatic pathway system. This is Tyrese theory about CSF shift edema. When brain injury and subacute hemorrhage in trauma raise the pressure in the system, and the intracerebral pressure remains lower than the system compartment. This results in the shift of CS driven by the pressure gradient through the virtual rubber space into brain. And this is principle of cystotomy. So we can, by the cystotomy, we can reduce brain edema. Actually, why we put the drainage tube into the basal system? This is people wrote the research in the animal. The perivascular pathway for influx of cerebral spinal fluid are the most efficient in the middle brain. So actually, this is a different phase. Use PET, different time the metabolism of the MRI. This is a time active curve of the middle brain at the front lobe. So the middle brain very uh, concentrated, is high concentrated in the middle brain compared with the front lobe. So we use basal cyst drainage is a very good effect. This is about biomarks of traumatic injury are transported from brain to blood via the glymphatic system. Uh, and now there's four unique approach to suppress glymphatic associated clearance. One is accompanies for deletion. Two is cystermagnocytostomy and sleep deprivation and actazolomide treatment. Uh, and the suppression of glymphatic clearance prohibits the delivery of TBI by marks to the serum. And cerebral influx. This is a new paper of last year. Cerebral spinal fluid influx drives acute ischemic tissue swelling. And so when the middle cerebral artery infraction, the the space Robert space is enlarged and now became edema. So when we use cystostomy, we can reduce the Robert space, and by drainage CSF, we can reduce the space vascular space pressure, then reduce the edema. This is about the depression effect about this about the glymphatic flow. When depression decreased artery pulsatility after craniectomy lead to impaired glymphatic flow. Craniectomy leads to bilateral decrease cerebral penetrating arterial pulsatility. So when we depression, so the bilateral cerebral pulsatility is low. So this results in immediate impairment of glymphatic CSF influx into brain, and prolonged failure of glymphatic CSF into brain, and craniectomy result prolonged failure of glymphatic CSF influx into brain until this is about 40 days, 28 days, 56 days. Actually, there is impaired glymphatic CSF influx immediate following depressive craniectomy and lasting out to a point between 40 and 80, 28 days following depression, regardless of whether cranioplasty is performed. And so at this time, we can place the ball about 1 month, 1 month. And so only cranioplasty is good for glymphatic pathway and good for brain function. Also, craniectomy induces extraglial activation. So also induce craniectomy also induce microglia activation, increase the CD 6 to 8% area. So they can, when cranioplasty, we can put the forward the date about glymphatic effect. Also, craniectomy impairs object memory and coordinate movement. This when we cranioplasty, we can we can improve the brain function and novel object recognition. This is microcirculation about CSF. So this is the lymphatic drainage and the connective influx glymphatic system of the brain. So when the uh, when the brain trauma and also there is immune complex disrupt the perivascular drainage of the throat. So there's a lot of immunocomplexes. So uh, when we do the cystostomy, we can reduce the refraction. This is a perivascular space. By reduce by drainage CSF, we can get a lot of blood CSF come out and reduce reduce immune reflection. So thus we can get a better brain function. So this is my understand about the glymphatic system and the cystostomy pathophysiology. So this is my my introduce this problem. Thank you all of you and thank you for your attention.